This is an exciting time to be able to provide care to patients suffering from acute stroke. My name is Ryan Borden. I am one of the emergency medicine physicians here at Health Partners. I'm also a member of the region's emergency department quality improvement team. I want to take a few minutes to discuss some of the recent advances in stroke care, as well as some of the changes that will be implemented to improve the care we deliver to patients suffering from acute stroke. First, it's important to recognize that Regions is a certified comprehensive stroke center. This is a designation provided by the American Heart Association, the American Stroke Association, and the Joint Commission. In fact, we were the first certified comprehensive stroke center in the state of Minnesota. To become a certified comprehensive stroke center, one must have expertise in caring for patients suffering from acute stroke, as well as several other key resources. These include advanced imaging availability, including MRI, MR angiography, CT angiography, digital subtraction angiography, transcranial Doppler imaging. One must also have 24/7 access to these advanced imaging modalities, OR availability, and endovascular treatments. Here at Regions, we also have a neuro-intensive care unit, and we have experience and expertise in treating patients suffering from large ischemic strokes, intracranial hemorrhage, and some arachnoid hemorrhages. As a comprehensive stroke center, not only do we have to report all the typical quality metrics, but also specific metrics related to being a comprehensive stroke center. There are multiple publicly reported measures, but there are several that the emergency department can impact. And these include the treatment with alteplase for patients suffering from acute ischemic stroke, documenting an NIH stroke scale in patients suffering from acute ischemic stroke, reversing anticoagulants in patients suffering from intracranial hemorrhage, and ensuring that patients who are suffering from large vessel occlusive strokes receive timely interventions in the form of endovascular treatments. I'd like to take just a minute to dive into each of these measures that we can affect in a little more detail. The first measure, STK4, is specifically related to patients who receive alteplase for acute ischemic stroke. This measure looks at just a subset of this patient population. Specifically, it looks at patients who receive alteplase and present to the hospital within 2 hours of their last known well time. What this measure looks at is for that subset of patients, how many of those patients got alteplase initiated within 3 hours of last known well. The next three measures relate to comprehensive stroke centers only. The first measure relates to documenting an NIH stroke scale. This is especially important to patients and the care team that will be taking over care once the patient leaves the emergency department. The initial NIH stroke scale is one of the most important factors that determines prognosis for patients, and that is why this is so important. What we're asking providers to do is document an NIH stroke scale on all patients presenting with stroke, but especially patients who are receiving interventions, either alteplase or endovascular treatments. What this first measure mandates is that the NIH stroke scale is performed prior to alteplase administration or endovascular treatment. For patients who are not receiving alteplase or endovascular treatment, the NIH stroke scale must be documented within 12 hours of arrival. The next measure relates to patients suffering from intracranial hemorrhages. This measure specifically looks at patients who suffer an intracranial hemorrhage and are on some form of an anticoagulant. What this measure requires is that for patients who are anticoagulated and have an INR greater than 1.4, that a reversal agent is given. And this can be IV vitamin K and or PCCs, prothrombin complex concentrate, or Kcentra, or FFP. The last measure is one that we expect to come the first of this coming year, and this relates to patients undergoing endovascular treatments. More to come in the future regarding this. Here at Regions, we also have several goals for patients suffering from acute ischemic stroke. And these may change with time, but right now our goals are that patients get that first CT image within 10 minutes of arrival, that after the first CT image, the alteplase order is placed within 10 minutes, that the alteplase, if indicated, is administered within 30 minutes of patient arrival, and for patients suffering from large vessel occlusive strokes, if they are a candidate for endovascular treatment, that they have arrival to skin puncture times less than 70 minutes. What follows is educational content related to how we care for patients suffering from acute stroke. We think you will find this information helpful and hope you can utilize these processes to deliver the best care possible to patients you care for who are suffering from acute stroke. Before we review some of the recent literature and how these publications will impact stroke care at Regions, I want to quickly reflect on the great job everyone has done with the recent EMS Street to Treat project. I wanted to go over data from patients who presented with stroke in the year prior to implementing this protocol and the year after implementing this protocol. The goal of this project was to decrease the time it takes for patients suffering from acute ischemic stroke who present via EMS to get their head CT and to get alteplase administration if indicated. This slide summarizes the data 1 year prior to implementing this protocol and 1 year after the protocol. Our door to CT time on average decreased from 14 minutes to 6 minutes. Our door to alteplase time decreased from 59 minutes to 51 minutes. Meanwhile, our symptomatic hemorrhage rate decreased from 3.4% to 2%. We were seeing more stroke activations after implementing this protocol. In the year prior, we had 203 stroke activations, and the following year we had 274. We've also admitted more alteplase since implementing this protocol, with 29 cases in the year prior and 51 cases in the year after. So I just want to thank everybody for their continued support and great work regarding the care we deliver to stroke patients. Let's move on and talk about some of the changes that are going to occur here at Regions. The first has to do with the elimination of Code Gray. We're going to just have Code CVA for patients presenting with stroke. Now this will only be for patients who meet certain clear criteria. The next change has to do with inclusion and exclusion criteria for TPA or alteplase. In February of 2016, the American Heart Association, in cooperation with the American Stroke Association, released new inclusion and exclusion criteria. Therefore, we've updated our TPA or alteplase checklist. And then the last major change has to do with a new treatment pathway for patients needing endovascular treatment. This will be for patients suffering from large vessel occlusive strokes in the anterior circulation. So let's move on and dig into these in more detail. So Code CVA. We've decided to get rid of Code Gray. First, we find that this is somewhat confusing. Second, we've had such success with our EMS Street to Treat program that we want to mirror this for patients who present via triage. The whole idea is to get patients who arrive via triage back to the CT scanner to get their workup initiated as soon as possible. We're going to use the exact same criteria to initiate a Code CVA as our EMS colleagues are using. And what this entails is having a positive Cincinnati stroke scale, which is 66% sensitive for stroke, and have symptom onset within 8 hours. Now the reason we chose 8 hours is because that's what our EMS colleagues are doing. We know that TPA can only be administered within 4.5 hours of onset of symptoms. And you'll see later on that our criteria for endovascular treatment is within 6 hours. But to keep these two processes the same and to eliminate confusion, we've decided to keep everything the same and just have a positive Cincinnati stroke scale and onset of symptoms within 8 hours. However, if providers need the resources of a Code CVA or feel like a patient would benefit from such interventions, providers can call a Code CVA at their own discretion. When a Code CVA is activated, the patient will go directly to the CT scanner where the stroke team will meet the patient. Now, if nursing or EMS or the provider feels the patient needs resuscitation in a room first, you can cancel this process at any time. Regarding our Code CVA process, there are a few important numbers to remember. First is time from onset of symptoms. And really there's only two numbers you have to remember right here, and that's 4.5 hours and 6 hours. IV alteplase can be administered within 4.5 hours if a patient does not have contraindications, and endovascular therapies can be implemented or utilized within 6 hours of onset for patients who meet criteria. So again, the numbers you want to remember here are 4.5 hours and 6 hours since onset of symptoms. The other number that's helpful to remember is a blood pressure of 185/110. This is the blood pressure we want to be less than in order to administer alteplase. Now, when a Code CVA is activated, what that does is it provides additional resources. First, the CT scanner is cleared. This allows the patient to get that critical head CT. It also notifies our radiology colleagues, and this allows them to get us a rapid read and help coordinate care as well. If a patient obviously has a anterior circulation large vessel occlusion, then they can help coordinate whether this patient would need an endovascular treatment. It also notifies neurology and pharmacy in case TPA is necessary. So let's talk about the code CVA process. So this is the updated algorithm, and I'm just going to highlight a few things here, but this will be up on the EdNet quality site, and it'll also be available on EdNet if you just type in code CVA. Really, when the providers get involved, you're right here at this box, but there's a few things to realize what happens ahead of time. And really, if a patient is having signs or symptoms of stroke, they're going to do a few things, whether they arrive via triage or whether they arrive via EMS. First, they're going to perform that Cincinnati stroke scale, and they're going to get the last known well time. And those things are going to be what trigger our code CVA. So positive Cincinnati, and again, last known well within 8 hours, that can trigger our code CVA. Now, if a patient is arriving via EMS, several other things are going to occur. Most likely the patient will have a fingerstick glucose performed. Hopefully an IV will have been placed if possible. And care will already start to be coordinated through MRCC. This is how you might get a heads up from the charge nurse about a patient suffering from stroke on their way to the ED. And this will help you kind of manage the department prior to this patient's arrival. If a patient arrives via triage, we're not going to have as much of a heads up. Things are going to happen a little more quickly. But again, the same trigger criteria will be used, which is a positive Cincinnati stroke scale, and again, a last known well less than 8 hours. If this happens, there will be emergency broadcast over Vocera saying code CVA to CT scanner. When that happens, the patient will immediately be brought back to CT, where the stroke initial workup will be started. That's where you as a provider get involved. One of the first things that's going to be really important is we're going to ask that you really get that timeout. Just like we do a timeout for our TTAs, really call for that stroke timeout. We have a poster on the wall that will help both nursing or our medic from triage or our EMS colleagues if arriving via EMS to go through a very scripted, quick patient handoff. And we're asking that whoever is doing the handoff that they tell us what the deficit was on the Cincinnati stroke scale, when the patient's last known well was. If anybody else is coming, that will help with consenting the patient for TPA and getting pre-hospital information or more about what the patient's initial symptoms were. And they'll also tell us things like previous treatments, like what was the blood sugar and if there's an IV in place. This should be a very rapid patient handoff. At that time, we're going to ask that you allow the coordinator to arrive at the patient if this hasn't been done. Now, if the patient arrives via triage, the patient may already be arrived. However, if the patient has not arrived via triage, just give the coordinator a few seconds to put a wristband on the patient and so that you can get that critical information out of Epic and begin placing orders. At this time, we ask that providers decide whether the patient is safe to go to the CT scanner or if the patient will be better served by going to a room for resuscitation. And so this is going to be, like we do for any patient, a quick ABC exam. The emergency medicine provider, it's their discretion to determine where the patient goes at this point. Now, there's a few things that we recommend you do if the patient is safe to go to the CT scanner. It's probably worthwhile to repeat the Cincinnati stroke scale to see if the deficit's still present. And at this point, you could also move on to begin your NIH stroke scale. If there's two of you there, say a mid-level and a staff provider, one could begin their assessment and the other person could begin doing chart review, ordering the initial order set via the stroke order set to get that head CT ordered. Again, please place the order for a CTA. At this time, the nurses will probably have a blood pressure for you, and if the blood pressure is greater than 185 over 110, consider labetalol or starting an acardipine drip. You'll also have a nurse who will get you IV access and can get you that iStat creatinine. Prior to going to the CT scanner or transferring onto the CT gantry, the patient will be placed on a weighted bed. This will get a weight in case TPA is necessary. At this point in time, the patient will get their head imaging and, if indicated, the CTA of the head and neck. From here, things move forward like they previously did. If the patient has a hemorrhagic stroke, well then you're going to change your treatment paradigm and follow the code CVA hemorrhage order set or treatment as you think necessary, and basically you'll fall out of this protocol at that time. If the patient's clearly not having a stroke or you get other information, well then you would also fall out of this pathway. However, if the patient's suffering from acute ischemic stroke, then you can do a couple things. If they meet inclusion criteria for alteplase, we ask that you get this ordered and begin going through the alteplase indication, contraindication checklist and talking to the patient and family about alteplase treatment and getting consent. At the same time, you must consider whether the patient is a candidate for an endovascular therapy. And for this, we'll talk about criteria on a following flow diagram, but this is patients who have anterior circulation, large vessel occlusions that have an onset of symptoms within 6 hours. If a patient meets this criteria, they are then a candidate for endovascular therapy. However, again, if the patient's a candidate for alteplase and the patient's been consented and there's no contraindications, then please order the IV alteplase and get this administered as soon as possible. Just like before, immediately prior to administering the alteplase, perform a TPA timeout with nursing. So let's talk again just really briefly about what that stroke timeout entails, because we've really pushed this with our EMS providers and we're really going to train our frontline staff out in triage about this. So again, as soon as the patient arrives, please call for the stroke timeout, and this will follow this very formulaic script, which is the Cincinnati Stroke Scale Abnormality, the last known normal, anybody else who's coming to the hospital, and any treatments administered thus far, which is mainly IV placement and what was the finger stick glucose. Next, we're going to quickly go through some of the code CVA roles. Now, you'll be able to click through these, especially the roles that don't pertain to you as a provider, but let's go into the staff and mid-level roles in a little greater detail. So again, when a patient arrives with a code CVA, there's going to be some pre-notification. If the patient arrives via triage, that might not be much notification. They might just be coming back to the CT scanner immediately. But if they're coming via EMS, you'll probably get a heads up from the charge nurse because MRCC will have already been involved. Once the patient arrives, you're going to do your stroke timeout. You're going to allow the coordinator to quickly place the ID bracelet on the patient. At that time, you're going to do your ABC assessment to determine if the patient needs a stabilization room or if they can go to CT. You're going to perform your NIH stroke scale. You're going to check the patient's blood pressure to see if they need their blood pressure addressed for severe hypertension. And then you're going to proceed to CT. Please put the orders in using the stroke order set as soon as possible. Neurology, if during business hours, will likely come to the department to help manage this patient, but they may call in if they're not in the department. If there's no hemorrhage and the patient is suffering from an ischemic stroke, please use the TPA checklist to monitor for any contraindications and order the TPA if there are no contraindications. Once the TPA has been ordered, notify the RN so that he or she can prepare to administer this. The video will now continue showing the various roles for a code CVA. You can pause on any slide to read in more detail. So just to summarize the various roles, our EMS colleagues or the triage nurse or medic will hand the patient off using that clot mnemonic. Our coordinator is then going to arrive the patient so that we can do chart review and enter orders. Our nursing colleagues are going to get IV access if not already obtained, obtain the weight of the patient, so we'll have that if alteplase is going to be administered, and get our ISTAT creatinine for our CTA head and neck. If a patient arrives via triage, we'll also get a finger stick glucose to ensure that hypoglycemia or severe hyperglycemia are not the etiology of the patient's stroke-like symptoms. At this point, the mid-level will determine if an immediate intervention or resuscitation is needed prior to imaging, and if not, we'll repeat the Cincinnati and begin their stroke assessment. At some point during all this, whoever is doing the stroke assessment will also have to perform an NIH stroke scale so that this can be documented in the computer. The other provider, whether the staff physician or mid-level, will then place the initial orders using the stroke order set and begin a chart review to see if there's any contraindications to alteplase. So next we're going to talk about the new inclusion and exclusion criteria for IV alteplase. Again, in February of this year, the American Heart Association and American Stroke Association released the following document. And what this does is an update to the inclusion and exclusion criteria for IV alteplase for patients suffering from acute ischemic stroke. The indications for IV alteplase are ischemic stroke with a deficit, onset of symptoms within 4.5 hours before beginning the IV alteplase infusion, and age over 18. Now, this was a very lengthy document, over 70 pages long. But the expert stroke committee got together and was able to distill this down into a one-page checklist. This is broken down into inclusion criteria and exclusion criteria, and we ask that providers use this document to determine if a patient would be a candidate for IV alteplase. Again, there's both absolute contraindications and relative contraindications. Our neurology colleagues are available to help make decisions on a case-by-case basis. The checklist will be on the workstation on wheels for all code CVAs. It'll also be on EdNet. We're going to switch gears now and briefly talk about the NIH stroke scale documentation. Not only is this a CMS measure that is reported and for which we're being judged, but it's also incredibly important to patients. This is one of the single strongest predictors regarding prognosis, and that's why it's so important. Both neurology and our rehab colleagues really appreciate when we get this documented. So, a couple ways to document the NIH stroke scale. Now, if one of our nurses documents a code CVA in the Epic Navigator, a best practice alert will trigger. And there's a way to get to the stroke scale directly from this best practice alert. First, one can click on Go to Stroke Scale Assessment. Now, if you're not ready to do that, or you can't do it at the time, you can click the Remind Me in 1 hour button. I'll also show you another way to get to the place in Epic where this can be documented. The other way to do this is to go to the trackboard and highlight the patient. In this case, you can see I'm in the Epic playground, but purple training has been highlighted, this 36-year-old male. And you can see this large red AL points right to Stroke Scale Assess. If you click that button, what will pop up is the NIH stroke scale. An important first step is to document the time the NIH stroke scale was performed. When you first open this flow sheet, the current time will self-populate. We ask that you go back and enter the time that the NIH stroke scale was initially performed. Once you've done this, you just click the appropriate boxes, and at the end, it will auto-tally and calculate the stroke scale for you. By accepting this, it will enter this into Epic so that it can be recorded, and this can self-populate into your note as well. So now we're going to talk about endovascular treatment for acute ischemic stroke. In 2013, things were not looking very good for endovascular options. There were 3 negative trials. However, since then, we've had 7 positive trials showing disability benefit. The first was Mr. Clean, and this trial is unique in that it showed a 13.5% disability benefit contradicting prior trials. It also used a protocol that is very practical, which we'll talk about in more detail. But since then, there has been ESCAPE, which showed a 24% disability benefit, Extend IA with a 31% disability benefit, SWIFT Prime, 26% disability benefit, Revascat, 16%, Thrace, 11%, and Therapy, 8%. So you can see that there's an 8 to 31% disability benefit from these endovascular interventions. So here at Regions, we've decided to use the Mr. Clean protocol. And the reason we chose this protocol, well, it was the first RCT to show benefit. This trial actually went to completion. It wasn't stopped early. It was unique in that it didn't use special imaging. All that was required was a CTA of the head and neck that showed an anterior circulation occlusive stroke. It was multi-center. It was the largest positive RCT to date. There's no upper age limit for patients who can be enrolled in the study. Patients were able to be treated with endovascular intervention within 6 hours. So this is one of the inclusion criteria. If your patient could get to the endovascular suite within 6 hours of onset of symptoms. Patients had to have an NIH stroke scale score of 2 or more. And again, they had to have an occlusion of the anterior circulation causing their stroke. So here at Regions, we are following that protocol. One can trigger the endovascular treatment pathway if the patient has had an onset of symptoms within 6 hours and if there is an occlusion in the anterior circulation. Now, if you feel like your patient would benefit from an endovascular treatment and they fall outside of these parameters, you can talk to neurology to discuss this because there are other trials showing longer windows than 6 hours. It's just that those treatment protocols were a little more complicated. Those studies tended to be stopped early. So let's talk about pathways for endovascular treatment. There's 3 pathways, and this has to do with where the patient is coming from and what's been done.
The vast majority of the time, it's going to be a patient that presents to Regions that you're doing the initial workup on. But however, a patient could get transferred in and have been given IV alteplase, but may not have advanced imaging such as CTA of the head and neck. They might just have their non-contrast CT. Or maybe a patient was actually transferred in, had CTA head and neck, but had to come to the emergency department before going for endovascular treatment. Let's start with this first protocol, as this will be the one that is used by far most often. How this works is when you get that CTA of the head and neck, neuroradiology knows to read that stat. What they'll do is they will call the ED provider that ordered the study to discuss the results and to say this patient could benefit from endovascular treatment. Now you'll have to talk over the exact details of the patient and the onset of symptoms. Neuroradiology will also call our neurointerventionalists and give them the heads up that there's a patient that could benefit from endovascular treatment. At that time, the neurointerventionalist will call the ED and talk to the provider to get additional information and to help make some recommendations whether the patient would benefit from such a treatment pathway. At that time, the team will decide to proceed with endovascular treatment or not. If you decide to proceed with endovascular treatment, several things will happen kind of behind the scenes. The neurointerventionalist will talk to MRCC to activate the team. Really what we're asking the ED to do at that point is make sure that the nurse is aware that the patient's going to be going to endovascular treatment and to do a couple things if possible. Inform the patient what the treatment plan is, ensure the patient has 2 IVs, that the patient's on a cardiac monitor, undress the patient and make sure they have a gown on if possible. When there's time available, they've asked that we shave the groin similar to our patients going to the cath lab. And also let the family know what the treatment plan is and have them go up to IR as well. Again, much of this can be done by the nurse that's caring for the patient, but this is something providers can help with as well. Now, this algorithm, again, will be on EdNet, and I would just like to draw your attention to the very bottom for the inclusion and exclusion criteria for endovascular intervention. They're right here. And just, again, it's anterior circulation occlusion, either the internal carotid artery, the middle cerebral artery, or the anterior cerebral artery. A last known well time, less than 6 hours, and an NIH stroke scale score greater than 2. Those are our inclusion criteria for this treatment pathway. I'm going to quickly just go over the 2 other algorithms that will be on EdNet. And again, these are for patients that are transferred from an outside facility. Here you can see that this one, the both non-contrast head CT and the CT of the head and neck have been completed. Now, a patient may need to come to the ED because the endovascular team is not on site or will not be there by the time the patient arrives, or maybe they're concerned that the patient may need further resuscitation or reevaluation given the patient was likely given TPA prior to coming. So here, again, the neurointerventionalist will get a heads up that there's a possible patient. There'll be care coordination between the neurointerventionalist and the outside facility provider to discuss the care of the patient and to see if endovascular treatment is an option. Regions Direct will be involved and we'll discuss this with neurology as well. At that point in time, it'll be decided whether or not a patient's a candidate for an endovascular treatment. And if so, several things will happen behind the scenes with MRCC and arranging transportation. What I want to draw your attention to is if the IR team is not in-house, the patient will come to the ED for assessment and monitoring until they can go to the IR suite. Again, you can see that the inclusion criteria for endovascular treatment is at the bottom of this document. And then the last algorithm is for patients who had their non-contrast head CT but have not yet had a CTA. These patients are going to come to the emergency department if they are a candidate for endovascular treatment. This is so that we can expedite advanced imaging. Also, we're going to determine if a patient's been given alteplase or not. If the patient has been given alteplase, we're going to repeat their NIH stroke scale before getting a CTA. And then, again, you'd fall into that prior treatment algorithm to see whether or not a patient would be a candidate for an endovascular treatment, and you get them to the endovascular suite. The last thing I'd like to cover is a couple resources that can help manage complications related to alteplase. The first is an algorithm for patients to develop hemorrhage after being given alteplase. A couple things to point out. As soon as intracranial hemorrhage is suspected, and this can be decreased level of consciousness, worsening pre-existing neurologic deficit, new headache, nausea, vomiting, the TPA should be stopped immediately and a stat head CT should be ordered. Now, if there's no hemorrhage, you exit out of this algorithm and you can resume your TPA or reevaluate the patient. If there is hemorrhage, it's recommended that labs get sent stat, CBC, INR, and PTT, as well as fibrinogen. At the same time, you're going to order either 8 units of fresh frozen plasma or 8 units of cryoprecipitate or prothrombin complex concentrate or Kcentra. With this, you'll also order 8 units of platelets, and you'll consult neurosurgery and hematology. Then, based on the patient's labs, you're going to give another 4 units of fresh frozen plasma, cryoprecipitate, or half the dose of the prothrombin complex concentrate, again Kcentra. If the INR is greater than 1.5, the PTT is greater than 1.5 of normal, the fibrinogen is less than 200, or the fibrinogen drop from admission to repeat is greater than 200. You will then recheck labs or CT in 2 to 4 hours, or if there is more deterioration in the patient's neurologic status. Again, this algorithm will be on EdNet, and again, at the bottom of this algorithm, you can see the Kcentra dosing. Angioedema is another complication that it can occur following administration of alteplase. Fortunately, nursing is monitoring these patients closely, so this can be recognized early. If this occurs, immediately stop the TPA infusion. Then you're going to consider all your normal treatments: Benadryl, H2 blockers such as ranitidine or famotidine, methylprednisolone, and epinephrine. You're also going to want to take control of that airway early if necessary. So to summarize, I just want to reiterate the importance of using the order sets. So for stroke, please just type in ED stroke or ED CBA, and there's the workup order set there. There's also an order set for alteplase or thrombolytics. Please ensure that you document the NIH stroke scale in Epic. Important numbers to remember are 4.5 hours, 6 hours, and a blood pressure 185/110. And again, if you order a CTA head and neck, there's no need to order a non-contrast head CT, as this is part of the CTA head order. Thank you for your time and the great care you deliver to patients suffering from acute stroke.